everyone, and welcome to the Byolete podcast, the podcast where we discuss the science behind the brand. So, welcome to episode 4 of the new podcast series. We are back in the house today recording. So, last week, obviously, for those who have watched it or listened to it, you'll know that we were at the podcast show in London, which was a really great experience. What did you think?
I mean, it just shows how much we need to probably put into our own podcast. But yeah, there's more out there than what we thought. We thought it was just going to be a small convention. But what did you think?
Yeah, no, I agree. I think it was an eye opener, like you say. We learnt a lot. I think it was geared probably more towards people who had well-established podcasts. The knowledge and the things that you were getting taught were so in depth and probably not really relevant to us per se at this moment. But we did take a lot from it. We met some lovely people. We also got to meet Anisha and Sanjay in person. So Anisha's got the Pharmacist Diaries and they've got the Anisha and Sanjay podcast. I think it's actually behind the podcast now, isn't it, that they've called it? But they're just friends of ours who we ended up meeting down there. So that was really nice. And yeah, it's given us a new lease of life for the podcast and where we want to take it. So all in all, it was a very good weekend and we're very excited to continue on our podcasting journey. What would you say?
Well, yeah, I agree with it all. I mean, the one thing that I took away from it was the idea of building a community and an audience,
Yeah.
which is why we've been discussing. And this is why I've got a question to open up this podcast with you,
Okay.
which will then go on to the whole topic we're discussing. But we want to try and make the podcast, I mean, what do you think about making it more user-friendly, not too scientific, get the points across,
Yeah.
make it a bit light-hearted in the sense that we're not going to be cracking jokes, but
Yeah.
make it more light-hearted, easy to listen to, and hopefully people take stuff away.
Yeah, I agree. I think we've always struggled with making it informative, but also not too in depth that people wouldn't be able to understand it, and then also not too simple, so that it came across as if we didn't really know much. It's hard to
Medical
strike the
podcasting's
balance.
hard because you need to have credibility, but then if you go too credible, it becomes boring to listen to. People don't take anything away from it, and we're targeting people who maybe want to have a bit more of an insight into the health, don't we?
Of course, yeah. And we just want to raise awareness specifically for cardiovascular disease, especially at this moment. And so, yeah, if anyone is interested in it or knows anyone who is interested in it, obviously send them our podcast, and hopefully we can educate you and give you some practical advice to take away from our podcast that you can implement in your own life. And yeah, we're doing it with you as well, which I think is an important thing.
That's a good point. So last week we discussed Apo B.
Yeah.
We're going to be discussing that a bit this week because it becomes a part of the whole cardiovascular picture.
Yeah.
But the one that we're going to focus on this week is triglycerides.
Yes.
So the question I've got to you,
okay,
which you can't look, this is the one thing I am actually making reference to, is out of the 4, who has or what has the highest plasma triglyceride level?
Okay.
Don't completely quote me on this because I've had to look at the values. The 4 things or objects, people, animals are me,
Okay.
a lion,
Okay.
a giraffe,
Okay.
and a tiger shark.
Oh, okay.
Who's got the highest? Who do you think's got the highest?
Triglyceride
Yeah.
level? A really random question. So what I'm going to say is based purely on maybe the diet of what these people eat. So if we take you, for example, you've got a diet that is omnivore. So you eat plants and you also eat meat.
Okay.
Typically. A lion usually is a predator who is a meat eater, so they're usually carnivores.
Yeah.
So with that, meats are usually higher in saturated fat. A giraffe is usually a herbivore, and then a tiger shark, I actually don't know what they eat, to be completely honest with you. If they do eat other animals, then I'm going to say just because I'm thinking if they're in the water and the water's cold, they may need more fat storage, and so they may need to store So I'm going to say
Go on.
a lion. However, if a tiger shark is a meat eater, then potentially that.
So the tiger shark's got the lowest.
Oh, wow, okay.
Yeah. Then, so that was 0.3.
Okay.
These are in millimoles per litre, by the way, for anyone listening.
I was going to say, so it's like...
In terms of American listeners, I believe I think it's 88.6 times less than milligrams per decilitre.
Okay.
I've looked into all this recently. But the next one is giraffe, 0.45 millimoles per litre, lion at 0.59, and then me at 0.81.
Oh, okay.
And my level is actually quite low, which we'll get onto.
Okay. Okay, that's interesting.
It is.
I wouldn't have... Now I'm thinking about it though, like I did see with the tiger. Yeah, I don't know. Really interesting, but...
So the reason I brought this up is because triglycerides are normally overlooked, would you say?
Definitely.
And some of the things that may make sense in your brain, when we've actually looked into it, and I've looked into it, don't make sense at all until you delve deeper into it.
Yeah.
So triglycerides, I think, let's go into what they are.
Yeah.
So a triglyceride are 3 fatty acid molecules attached to a glycerol backbone, found in a lot of things within the diet.
Yeah.
And what we do when we eat any food, basically to absorb it, we normally digest it into its fatty acids, glycerol, absorb it across the intestine, and then before we send it off into the body, we package it back up into a triglyceride. There are some instances where you will get short chain fatty acids just coming through on their own.
Yeah.
And then this is, well, that's it really. It goes to the liver via the lymphatic system, and then it goes through all the processing later down the line. But I don't think we give it enough credit.
No, I agree with that completely. And I think before looking into triglycerides, obviously we have been looking into lipid panels for a while. Triglycerides have always been one that I've been like, oh, well, you know, they don't really do it much, you know, they don't really stand for much. They'll be raised if you've eaten a meal, potentially. So that's why we would usually ask someone to fast on it when they're having the lipid profile done. If you don't fast, don't worry about it, because, you know, it just means that, you know, you might have higher triglycerides. And it's definitely something in healthcare, from my point of view, and probably a lot of other health professionals listening to this, that we don't really look at triglycerides. The main one, obviously, we've discussed a lot, is LDL cholesterol, which is what we, you know, class as the bad cholesterol, and is the one that we would associate with, you know, poor outcomes. And so, like you say just before, it's so interesting that we've been looking at it this week and over the last couple of weeks, that actually it plays a greater impact on health outcomes than what we do give it credit for. And it'll be very interesting to go into this podcast.
Yeah, I mean, I nearly went into too much science. It's going to be hard not going into too much science. But you just said we encourage people to fast before a blood sample.
Yeah.
Why is that with triglycerides mainly?
So triglycerides are obviously, like you just said, taken from your diet. And so if you've just eaten a meal, immediately after you've eaten it, these triglycerides will be floating around in your bloodstream. And so you may get an abnormally high level, like if you've just eaten a meal, because that's, you know, that's just the way that it'll work.
Yeah, I did actually look into something before, and they were saying, although it's good to fast for a triglyceride level or lipid sample, sometimes they advise against it because it gives you a true representation, because not many people are within the fasted state. In my opinion, I think, if anything, depending on whether you do fasted or not, especially if it's non-fasted and it's high, I would definitely repeat a fasting sample.
Yeah.
To see whether it is just because you've just eaten a high proportion of fat. If it is the fact, that's fine, we can manage it accordingly. But if it is genetic or something else, then it needs to be looked into deeper.
Yeah, because actually just thinking about it now, obviously with triglycerides, usually they're an energy storage. So usually it will be stored inside an adipocyte if it's not being used for energy immediately. And so you wouldn't really tend to see it hanging around in the bloodstream for too long, unless, like you say, there's something underlying.
Yeah.
And so, you know, even if it was fasted or non-fasted, it shouldn't be raised to, you know, to that much of a high level unless there was something going on. Do you agree?
Yeah. So to go on to the next points, I think we finish off what happens once it's been absorbed. So it's been absorbed through the intestine. Do you want to take it on in terms of how it gets to the liver?
Yeah, so like Lee just said, obviously, because it's a fat, it can't be transported through the lymph system or the plasma. as a fat. It has to be enwrapped or enveloped in something, and so that's where the lipoproteins come in. So immediately once you've eaten, it actually stores them as a chylomicron, which this chylomicron then, like you say, goes through the lymphatic system. It then goes into the bloodstream, and then it'll go to the liver, where the liver will take in the triglyceride, use it, for whatever it needs to do, and then if it within the liver, and then store some of it, or it'll either then send it out as a VLDL.
Yeah, and sometimes before it goes back to the liver, it gets used in the muscle or
Yes.
fat tissues, doesn't it?
Yeah.
And then it goes back as a remnant.
Yes.
But yeah, so the thing that we're getting onto, so this is for completeness, but once it's made its way back to the liver, this is where it causes or increases the risk of cardiovascular disease, is that triglycerides, once they're absorbed into the body after chylomicrons have come in, they're put out of the liver in VLDLs, very low density lipoproteins.
Yeah.
Their principal cargo, so like you said before, fats can't be transported unless they're in something because it's not soluble in water. So most of it is triglycerides in a VLDL with a bit of cholesterol esters, to some phospholipids, whatever, but it's mainly triglycerides. And their role is to go from the liver to go to muscle tissue or adipose tissue, so fat tissue, and then it's extracted. The enzyme, if anyone wants to know, is lipoprotein lipase, and it extracts the fatty acids from there.
Yeah.
Then, because it's removed that, it goes to an LDL, low density lipoprotein, which now has a higher cholesterol to triglyceride concentration.
Yeah.
Now, where does high triglycerides increase your cardiovascular risk? I'm asking you.
Sorry. So, if you have high triglycerides, obviously it means that you've got an abundance of sort of energy, and so your body can store so much, and then otherwise it'll then push it out, like you say, as a VLDL. If it then, I'm trying to think now, if
it is complicated.
It's so
it's
hard
not
to
complicated.
explain.
Just there's so many stages to it. I meant in terms of once it's, like you just said, then the body puts it out in VLDLs. In people who've got a lot of triglycerides, the VLDL becomes so large, which has a lot of knock-on effects in terms of interpretation later down the line. I'm not going to go into. But then if they're so large, it wants to offload it to ideally an LDL particle. But they're not designed to to take triglycerides. So what they do is they swap triglycerides with the LDL in exchange for cholesterol. Now, because LDL, low density lipoprotein, principally carry cholesterol, the body has to upregulate its LDL production, doesn't it?
Yeah.
And I'll let you go on. That's what I meant. Sorry, I led you down some sort of
so basically you just get an increase in LDL, you get an increase in VLDL, and then ultimately there will be an increase in Apo B, which is obviously the molecule that we discussed last week. We know that an increase in Apo B is then also increasing the risk of atherogenicity or atherosclerosis, because there's more particles that are able to transverse the endothelium. So
yeah, that's it really. So triglycerides, if you look at it, it exerts this cardiovascular risk in terms of Apo B.
Yeah.
It doesn't do it primarily through high triglycerides, because you can go up to a level, from what we've read, or from what I've read, up to 400 milligrams per deciliter, which in the UK is about 4.5 millimoles per litre. Anything under, you focus on Apo B, because that's how it's going to exert its cardiovascular effects. Once the level gets above 400 or 4.5 in the UK, then you start looking at pancreatitis and other organ dysfunction, non-alcoholic fatty liver disease, and then we need to treat that accordingly. But triglycerides exert its effects through Apo B. There's a lot more complex.
It's so so complex, and I feel like
insulin resistance. You can do a whole podcast, which we will do on that.
Yeah, so insulin resistance will increase your triglyceride level, and then if you do find that you've got high triglycerides and low LDL, if you get your blood panel checked, that could be an indication that you do have some insulin resistance there.
Do you mean HDL or LDL?
Sorry.
Yeah.
Is that what I just said? What did I say?
LDL.
Sorry, no, low HDL.
Yeah, it's like the poor man's insulin sensitivity test, isn't it?
Yeah.
which mine actually was quite good. So
Yeah.
my triglycerides, going on to triglycerides, yours was 0.68.
Yeah.
Mine was 0.81. Now, in terms of percentiles of a population, we're about the 20th percentile for both sexes. And I think earlier on, I think in the late 80s, we might have just been a bit higher. So it is showing that the normal population is increasing in its level of cholesterol and lipid profiles. But I actually don't know where I was going with this. Oh yeah, so my HDL is 1.61. And the idea is that we aim for a ratio of 1:1 HDL to triglyceride. So mine's 2:1. So mine's quite good, showing that I'm insulin sensitive.
I think I read somewhere that it was better to be 2:1, or anything less than that could indicate potentially.
I read 1:1.
Did you?
Yeah.
Okay.
So again, that's the whole point of this. We're discussing it. We don't know the true answers, and that's what we're trying to make this podcast, is that we go off and we read so much. We always confer behind the scenes, so that when we come to do a podcast, it's more of a presentation. And it has been, even in this one, it's still been a bit of a presentation where we're like, oh, this is what this means, this is what this is. And only now we've had a bit of, okay, well, I've read something different.
I think really what I wanted people to take out of this podcast was that we should actually be looking at triglycerides. We shouldn't obviously, again, look at them in isolation, but they can give you a picture of what could possibly be going on. And I think historically, like I said at the beginning of the podcast, I never used to look at them really, unless it was like above a certain level where it was like, okay, what is going on with this patient? It was usually like, oh, it's okay. If the LDL was fine, then, we're not going to do anything about it. When really, we do need to be looking at it again, in the context of everything, looking at HbA1c, looking at maybe a high sensitivity CRP, which is like an inflammatory marker, just to see what is actually going on. And I think that as health professionals at this moment in time, because we're not really geared towards prevention, I think that's where we go wrong, really, where we just sort of treat it like an immediate sort of disease state rather than going, okay, well, there's something going on here. What possibly could it be?
Yeah, I mean, we discussed earlier that when we went through university, even clinical practice, if you looked at triglycerides, what was a triglyceride? We could tell you the structure. We could tell you basically what it's used for, but in terms of how it's manipulated in the body, how does it convert or convey any cardiovascular risk? I didn't know to the level of detail we've known over the past couple of years.
No.
So triglycerides are a big part of your cardiovascular disease risk profile.
Yeah.
Via increasing Apo B. And there's a few things that I looked into as well. I think you might have as well, in terms of these fad diets.
Okay.
Fad, I don't know why I've just said that, but anyway, I'm going to stick with it. In terms of carnivore, ketogenic diets, and you'll get people say, I've lost so much weight, I don't know, my lipid profile seems to be okay. Triglycerides have went down.
Yeah.
Blood pressure's normalized. But then if you actually test a lot of these people, the Apo B will be up. And that's because, again, it's so hard to not go back into it, but that's because the insulin resistance may have been corrected, but your triglycerides on the surface look well, but they've exported all the triglycerides into cholesterol carrier molecules, and then the Apo Bs went up. So actually their risk has gone up as opposed to go down.
Yeah.
But in terms of VLDLs, they are ironically the most atherogenic.
Yep.
If they're left as a remnant. But I mean, there's so much I can go into.
I know.
I really don't know where to cut off and where to carry on.
I think maybe what we should finish off with, because I think it's just a general overview of sort of triglycerides and like an introduction into it, would be to say, well, how would you lower your triglycerides? So if you had, a high level of triglycerides, what could possibly be going on, and then B, how would you lower them?
Okay, what could be going on if you've got high triglycerides could be insulin resistance.
Yeah.
That doesn't mean you're diabetic. It just means you could be on your way to diabetes, namely type 2.
Yeah.
And yeah, I mean, I'm trying not to put it across in scientific because it's all ApoC3 and LPL, blah, blah, blah.
Yeah.
That's the big one. I mean, increasing the amount of fat in your diet will increase your triglycerides.
Yeah.
Increasing the amount of carbohydrates and excess energy within your diet will eventually get converted to triglycerides, which then conveys your cardiovascular risk through Apo B again.
Yeah. Alcohol is that's a big one as well. So that gets converted, doesn't it, into fat, basically, in the liver. And so that it will be as a triglyceride. And so that, definitely reducing alcohol consumption, that can it can increase it if you obviously are having too much oil and decrease your levels. Omega-3, I think that was another one. I think triglycerides are associated with inflammation to some degree. Again, the science behind that is so complex that I'm going to have a look into that over the next couple of weeks to see exactly how it manifests and how it works. But omega-3 is involved in that inflammatory, cascade. And so increasing the amount of omega-3 is beneficial for triglycerides, because that's it's non-inflammatory. It is you've got omega-6, which is usually pro-inflammatory. What would be the opposite?
Anti-inflammatory.
Anti-inflammatory.
Oh,
So
I didn't know.
Sorry. Yeah. So omega-3s are the opposite. So they're supposed to be good for reducing your triglycerides as well.
Did you look into the difference between men and women with triglycerides?
No.
So I did.
Okay.
And I think it's actually better correlated with women. So triglycerides and risk for cardiovascular disease has a better link with women than it does with men.
In a negative way, you mean?
Yeah.
Yeah. I think I did look at it like a little bit, but I think it was to do with estrogen. So I think
I didn't look into that side. I didn't look into the hormonal side. I looked at it from
hormones, I think.
Disease profile.
Okay.
But go on.
No, I didn't look into it too much, but I just know that it was very briefly. I think it was like earlier on today. I read where if it must be something to do with the liver, because if you have a patient who is menopausal, who is being given HRT, so replacement with estrogen, and it's being given orally, it can increase triglyceride levels. So what they suggest to do is give it transdermally. So if you give it transdermal, it bypasses first pass metabolism, which means that it doesn't go through the liver. And so I'm presuming that it will be something to do with estrogen, and like it increases the ability to make triglycerides. But I know that there's definitely a link there. Again, something that I'll probably look into over the next couple of weeks, because it's so complex. But yeah, so I thought that's what you meant.
No, I mean, that's the potential pathology behind it, but I looked into just what was the correlation. So with women, it was the risk kept on increasing until about 200 milligrams per deciliter. I hate converting between the two, because all the papers I read are Americanized, because America, by the way, is so far ahead in comparison to the UK. In the UK, I'll go on to something that I wanted to talk to you about, but the UK is so far behind because the public don't want to know in general, and healthcare don't want to know. But so 200 milligrams per deciliter. So the risk kept on increasing to a certain point anyway, and then slowly, but kept on rising actually with women.
Yeah.
So it was a gradual increase.
Okay.
Whereas with men, from at lower levels, the increase was really sharp in cardiovascular disease.
Right. Okay.
So the idea behind this study was, should we be optimizing levels for individual sexes as opposed to having a generalized optimum normal level?
Yeah.
And all the definitions have changed actually from cardiology associations, because normal and optimal are not the same thing. I mean, being normal amongst a sick population is not optimal.
I mean, it makes sense, because what you just said before, before we just did this podcast, you said, "Oh, what was your triglyceride level, Jess?" And I give you mine.
Yeah, percentiles.
And then you said, "Oh, well, we're both in the same percentile for our age." But then
for our sexes,
for our sexes, but then the reference range is the same for both of us, which it does make sense. Yeah. It's crazy.
So in the UK,
but some things in medicine just really don't make sense, and we've learned that so much from doing this podcast that it blows my mind.
It is. Now, for people who want reference ranges in the UK, it's less than, depending on what lab you use, less than 1.7, 1.8 millimoles per litre.
Again, that is a normal level, not that it's optimal.
And it's give or take about the 75th percentile, meaning that 75% of the population will have a value of this or lower. In what way in life is 75% of people having something the normal or optimal level? It's not. So I think in America that's 150, isn't it? 1.7, 1.8 is about 150 milligrams per deciliter. So they're the reference ranges. The one thing I wanted to end on was I did a heart health check on the UK website.
Yeah.
What do you think mine was?
I think we did do this a couple of months ago.
Oh, did we?
Yeah.
Oh, I thought
Well,
it was
when I
something
say we
we've
did
not
it a
done.
couple of months ago, we were literally driving somewhere and I was like asking you questions and then I was like, you were like, what's this for? And then I'd
Okay.
told you. I did mine. I remember what mine was, and my heart health age was actually my age, was
Okay.
31. I think yours was a bit higher.
It was.
By how much? Go on.
36, so 6 years older.
Oh, okay.
But that wasn't the thing that's got me. So I've actually screen recorded it, because I want to do a video on it, was the advice that it gave me
Oh,
based
okay.
on my results. And this is how far behind the UK is in terms of treating these conditions, no matter what way you look at it. So it said 36, I think the risk was higher because of my family history anyway, but it said my BMI was 24.8.
Yeah.
So I'm 176 centimeters, I'm 77 kilos. I think I'm 11% body fat.
Yeah.
But it said you need to lose weight, increase your physical activity, and eat a clean diet. That was the advice it given. And the picture for someone on my BMI, the picture was this woman who was clearly overweight. I think she must have had a BMI 35, 40.
Oh, really?
Yeah, so it said I need to lose weight, do more exercise, and eat a clean diet. And then it went through in a few headings what that meant.
And it's just very generic.
It was generic.
Yeah.
It said that my total cholesterol was above 5, and this is suboptimal. It didn't ask me for my LDL cholesterol, only
really?
HDL.
Oh, right.
Said your
Okay.
HDL was okay, and this is cardioprotective,
Right. Okay.
which we'll go into. Unless you know the functionality of it,
Yeah.
it's useless.
Yeah.
Total cholesterol is pretty useless on its own.
Yeah.
I want to know what's happening. How is that being moved around my body? Where is it being stored?
Yeah.
That blood test doesn't tell me that. But the whole premise of that, that was it at the very bottom. It said, because I'm under 40, I won't be eligible for any intervention.
Right. Okay. That's interesting.
So we're talking about a disease that
Yeah.
progresses and manifests from
Yeah.
even in the womb.
Yeah.
We've had evidence, but at least from 5 to 10 years old, it is manifesting. And you can't have any intervention until you're 40. I
Yeah.
think that's pretty poor.
That is very poor. And again, one of the reasons why we set up this company, because
People
we
need to
need to do
know.
something about this.
Yeah. And it's when you think about 50% of men who are going to have a heart attack have it by the age of 65.
That's only
We're leaving a 25-year window for something that's manifested over at least the last 30 years
yeah.
to then intervene. Then we give medication, which people are against. I'm going to do diet and lifestyle. Well, if you're going to do diet and lifestyle, that should have happened 30 years ago.
Yeah. Yeah. Of course. I mean,
So
we get
what
that.
are we meant to do?
Yeah, we get
And
that all the time.
And we leave patients because they've got autonomy, and I understand where they're coming from. We leave patients to their own device, really, where we just say, okay, well, you want to lower it in a natural way. It never ever comes down. Very rarely does that number come down.
But to be honest, and I think, again, this is something that we've learned from doing this podcast. As a health professional, prior to doing the podcast, if someone would have said to me, oh yeah, I'll lower it by, my diet and lifestyle or whatever, I would have been like, oh yeah, okay, that's fair enough. Like, and give like very generic advice. But now looking into it, it's so complex that I think, because the health professional doesn't really fully understand, it's like, well, I think it's very difficult for them to then get the head around, or like the patient to then get the head around, which is even worse, like how to actually do it. Do you know what I mean? Where it's so complex.
I'm not fully putting the blame on the patient, by the way. I understand where they're coming from. I just blame the fact that they haven't had any intervention or education prior to that.
Well,
and then you've created this environment that is only, I don't know, doomed, basically.
Yeah.
There's no way around it. But on that cheery note, I think we wrap up the end of this triglyceride episode. I think we go into insulin resistance next.
Yes, I think that's a good one.
Or maybe just touch upon insulin resistance with triglycerides.
Yeah.
Have a shorter episode.
Mm-hmm.
And hopefully get better at this dynamic where we actually have a conversation. I actually might record it with you in a minute. So it's quite late. I think it's 11:05.
Yeah.
Late. I think we do it straight after this because it's not going to make much of a difference in terms of preparation. It might give us more of a natural conversation.
Yeah.
I'll let you finish it.
Well, yeah, no, thank you for listening to the episode. We hope that you enjoyed it. Just a very brief introduction to triglycerides. Obviously, I've been looking into it for the past couple of weeks. It is very complex. There will be more episodes that, about this, going into more depth into different topics. But we hope you enjoyed it. If you know of anyone who might have found this beneficial, then please send them this episode. As always, follow us on Instagram, on YouTube. We'll obviously leave all the links down below, and we'll catch you at the next one.